it's easy to make the diagnosis. It's important to do so and important to get the patient to recognise they've got a problem. That's the critical first step. The next difficult step, of course, is what you then do.
Yes.
Cold turkey, wean them off. What's your approach?
I offer patients the option that they can do either. Although I have to say, I think the people who do the best just are the ones who draw the line and go do cold turkey. It's something about, it's the way they approach things. The essential thing is to get off, is that they understand it could be making things worse. They understand that in general it's unhelpful, and they understand that it'll be stopping in a preventive working. That's we could talk about the evidence. There's some evidence around that. So engage them in the process, and then do you want to stop suddenly or do you want to come down gradually? You tell me. It's very often, I think it helps in practice to get a person to tell you what they want to do, because when they decide, I want to do it that way, they buy into a little bit to that's how I'm going to do it, because I didn't tell you how to do it. You told me how you wanted to do it. Good, great, let's do it your way. That's part of the art of medicine, I guess, or the art of anything that you're doing. And then I mean, you encourage them and need to provide them with a little bit of support in that. And that's where I think non-steroidals are legitimate. That's why, I mean, are a legitimately helpful treatment during that medication withdrawal period, say 3 days a week. Naproxen is my favourite, with or without an antiemetic, just to get them through the more difficult headaches as they're doing the medication withdrawal.
I mean, I think it's important to try and recognise what the underlying headache is. So if it's a migraine, which is usually the case, you can start them on preventatives as they perhaps a bit early, and also making sure you've got a good, like when you stop smoking, you actually nominate a date on which you do that, which is suitable. You don't want to do it in the middle of a stressful stressful period. The other thing I use quite a lot, and I don't know what you think about, is steroids. I find steroids very useful. And there's 1 or 2 trials coming through now that have suggested this, and by your face, you don't sort of think that's a good idea.
I mean, my experience with steroids is that they're great while people take them, and then there's a bit of a bounce back afterwards. So I've seen that often enough, and the studies that have come through have been rather short term.
They have.
So and the steroids, you go through medicine, the more drugs you use, the more problems you'll run into. Life is like that. So I like to use the ones I really know I have to use. So I don't usually do that. There's another study actually that's being done, a better one at the moment, and if the evidence is a little bit better, maybe I'll get a little bit softer about it. But for the moment, I try to avoid them because I've very often seen this rebound back, and that's quite problematic.
If you tell them off slowly, I mean, I just wonder if GPs are just a bit more familiar with steroids. We use steroids quite a lot in short course steroids, 3 or 4 weeks for obstructive airways disease. We're quite asthma.
Yeah, I'm sure.
We're a little bit not gung-ho, but we're just a little bit more perhaps happy about using steroids. And I find milligram per kilogram for 2 or 3 days, then reduce it over 4 weeks. I mean, it may just be my incorrect impression, but I think that just gives them the time to get themselves sorted out. Often their lives are out of control, gives you time to build the prevention up. And I find that quite a useful approach, but I guess the jury is out at the moment, really.
Yeah, the jury's out, but it sounds like a sensible approach. I mean, I've not got a real fixed view about it. As you know, that in my practice, I tend to see more people who've tried to withdraw and failed, because a proportion will. So my practice is like all of us, we've got our biases, and my referral bias. So I'm looking at a harder core bunch where I think that, this is the contrast, and the one, while we're talking is where you're seeing a patient, you're able to stop them before they even need to get near me or get near a hospital withdrawal. By the time they've come to me,
they're pretty hardened.
It's happened. They're a bit hardened, so I have to take them more. I guess I've got a different group to deal with. Yeah,
and ultimately you get them in and give them sort of all sorts of exotic intravenous stuff.
Yeah.
Let's hope that never has to get that far.
No.
Okay, well, I think the important thing is to recognise, and I think that's been very useful. So I think we'll stop there. In our next video is going to be a little bit about the actual history taking and examination. So thank you, Peter.